Hello and welcome. We're delighted to say hello and hear today from Dr. Brad Lichtenstein of the Breath Space. He's going to be sharing with us mind-body approaches to mental health. I know you're going to enjoy it. Welcome.
Well, thank you. Thank you, Robin. It is wonderful to be here with everyone virtually, and just imagine we're all together right now. So today, I wanted to talk about mind-body approaches to mental health. Just a little bit about myself. So, you know, I'm a naturopathic physician. I'm in private practice here in Seattle, but I'm also a professor at Bastyr University, where I supervise our mind-body medicine and behavioral curriculum and clinic. So just wanted to provide you some background for that. So today we are going to talk about several things here. I want to start off by setting the stage. And in order to do that, talk about self-regulation and resiliency. And that's going to include a conversation about the polyvagal theory and how that relates to techniques that we can use to regulate our nervous system, other mind-body techniques. And then I'm going to talk about one of the easiest, most effective ways for us to regulate our nervous system, and it's the breath. And we'll go through some simple approaches for that. I'd like to start with a quote by Joanna Macy, who's a Buddhist teacher and environmentalist. And this really speaks to the content of what I'm going to try to convey here today. Now, if we were to be given a pill to be convinced, don't worry, it's going to be okay, would that elicit from us our greatest creativity and courage? No, it's that knife edge of uncertainty where we come alive to our truest power. And I'd like you just to take a moment to think about that. And what do we do as healthcare providers, as advocates? How comfortable are we with sitting with uncertainty, with uncomfortable thoughts, uncomfortable physical sensations, not knowing? And so that's the overarching theme here in many ways. And this is something that I say to the people I work with, students or patients or myself all the time. Sometimes it's okay if the only thing you do today was breathe. We love to say in this productivity obsessed culture, I didn't do anything. There's never a time we're not doing anything. We're always doing something. If we're looking out the window and daydreaming, we're looking out the window and daydreaming. And hopefully I'll connect that with the nervous system in a bit. So we're going to start by talking about resiliency. It's a word that everyone's using now. About 2 decades ago when I was teaching, we didn't use the word resiliency as much as we used hardiness and some other things. But we're going to talk about the neurobiology of resiliency. And so let's just define the term. There's many definitions of what resiliency is. We can start with one from Psychology Today, that ineffable quality that allows some people to be knocked down by life and come back stronger than ever. And that's part of what we're talking about here. Other terms, just looking at how we respond to life events. What a time to be talking about this right now in the world with all these things going on. How can we get knocked down by life events and respond? Now, there's several different types of resiliency. It's almost like the nature-nurture argument in a way. There's natural resiliency. That seems to be what we are born with. And I just think of one of my patients that I worked with in hospice. I used to do hospice work, who had 8 kids in 10 years. And I always bring this up because people respond by going, I can't believe this. But she had 8 kids in 10 years. And she said to me, don't let anybody tell you differently. We do have favorites. That's what she said. But she said, I'm not going to tell you which ones they are. But what she also said is they're all different. They are, and she recognized that, when you talk to the 4th one, there's already been 3 before. So you're never really talking to each one the same way. But she said they do come in with their own innate way of being. Everyone is different. So the natural resiliency we have is that way that we are, our natural tendency that allows us to respond to things. The adaptive resiliency is basically known as the trial by fire resiliency. It's like when a crisis happens, how do you respond? And many of us know we could be, as myself, a meditation Buddhist practitioner, and we do this all the time, and we think, okay, I can handle impermanence and change, and then something happens, and we really find out how we respond. That's our adaptive resiliency, and we can learn and grow from that. Restored resiliency, on the other hand, is the kind of resiliency we learn. It's the kind of resiliency we work with, we train to do. And we're going to be talking about some practices to deal with that. Okay. Now, it says the importance of practitioner resiliency, and this just means provider resiliency, and I'd like it to be expanded to anyone that works with anyone. It sounds like everybody, right? It's important that all of us have some resiliency and cultivate, that restored resiliency, that other type of resiliency, so that we can learn more. It's important because, and we all know this, it improves our mental, physical, and emotional health. It decrease and identify the signs of burnout. It's important to know about resiliency. Burnout is real. It increases our compassion and empathy for everyone. And it helps us reconnect with meaning and purpose and joy in life. When I was in the counseling and health psychology department at Bastyr, I was core faculty there. I taught all their spirituality and psychology courses to the undergrads. There was a counseling and health psychology program, and we looked at spirituality and psychology. And we talked about one of the definitions of spirituality. I know this is a term that many people get a little bit uneasy to talk about, especially if you're saying, how do I talk about spirituality with clients, with patients? Only one of the 7 definitions of spirituality involves the transcendent, connection with a higher being. Other definitions of spirituality are about connection with other people, connection with nature. But the one that I gravitate to, and this is the basis of all my work really, is about finding meaning and purpose in life. And so that's one of the most profound definitions for me of what spirituality is. And so what I'd like to say is that for everyone working with anyone, we want to connect to that meaning and purpose. We're all spiritual practitioners. Burnout can really affect our feelings of meaning and purpose. And here's 3 areas of burnout. And you can see if you identify with any of these. Depersonalization. You find that you're just less sensitive, less concerned about the people you work with. And the other is just exhaustion. You were excited, you were enthusiastic, you felt engaged about doing the work, and now it's like, oh, is it Monday again? And the sense of low personal accomplishment. And I can attest to this. There have been times I felt burnout, and I was like, am I really doing anything? Have I done? And then we make that expansive to, have I done anything with my life? Those are signs of burnout. Now, what are the factors that lead to this? It's interesting when you look at studies. I'm just going to put these all up here for a second. It's interesting when you look at studies, the work with the individual patient or client is the lowest of the factors that lead to burnout. In fact, Medscape had an article about this, I think it was about a year or 2 years ago. I could find the reference, but only 20% of burnout factor was the work with the individual client or patient. The number one was lack of control over our work conditions. And any of you who have used electronic health records understand this. If you have to get this paperwork done, you have to ask all these questions in order just to see the patient and get paid for that time. Lack of control over the work conditions. And of course, that rolls into time pressure, chaotic work environment. And I don't want to lose this lack of alignment with values. That was actually in the Medscape article, the number one. When the institution or the organization with which you work has one set of values, but yours is different, when those aren't aligned, that's one of the main factors of burnout. I also teach motivational interviewing at Bastyr, and one of the things we talk about with behavior, a behavior is only a problem when it's not aligned with our values. So for instance, if I say I take care of my health, but I'm smoking, and I also believe that smoking isn't taking care of my health, then there's a problem. If I think smoking is fine, it's not causing any problem, then there's no problem with the behavior. So if that's about our values, it's going to call into question everything we're doing. If we feel that the institution doesn't support my values and then I'm not able to do what I'm meant to do or what gives me meaning and purpose, we're going to feel burnt out. We're going to feel like, what's the point? So I just want to put those out there because it will connect with our polyvagal theory. We'll get to that. I'm going to skip over this. This is just some of these questionnaires about physician well-being and looking at meaning and purpose. But I want to talk about this concept of hardiness. And this is what I used to talk about before the word resilience became really popular. Hardiness, I believe, was coined by Suzanne Kobasa. And she was looking at the health of individuals, the hardiness, how they could be resilient. And her first study, I think, was when Ma Bell, if any of you remember Ma Bell, the one phone company, broke up. And she was looking at the executives and the people that worked there and how they bounced back. And she found that there were three main categories that she called hardiness. She has gone on to do studies with breast cancer survivors, long-term survivors of HIV. So there's a number of studies based on hardiness, based on this work. But the very first thing was this idea of commitment. Commitment meant not only were you committed to your own healthcare. A person who's committed to their healthcare is, by definition in the medical texts, a difficult patient. Why? Because they ask questions. That's the definition of a difficult patient. You ask questions. So I'm going to tell you all, if you want to be healthy, ask questions, be difficult. Your doctor's not going to like it. Your provider's not going to like it. Well, it's not their life. So commitment was not just only that you were engaged in a committed part of your healthcare team. You just didn't bow down to the gods, the doctors, right? You were committed to your health, but you were also committed to other areas of your life. That's the thing, that your life wasn't defined by one single thing. I can't tell you the number of patients I had when I was doing oncology or HIV care who came in and literally said this sentence, well, you know, I'm HIV. I'm breast cancer. And if I had a good rapport with them, sometimes I'd say, I'm going to look in the medical dictionary here. And, you know, I don't see your picture under that. So we don't define ourselves by our illness. There's other parts of it. It's one part. The person who is committed doesn't say, why me? Well, we'll get to that. We'll get to that in the next one. There's other parts of it. So the next step of hardiness was called challenge. And this is what I was talking about. Challenges, they didn't look at it as a threat. Now, a lot of us in our new age lingo and in our attempt to be positive and do spiritual bypassing will often say, this isn't a difficult issue. This is a challenge. It's a challenge. When really it's just difficult. What we mean by the word challenge here is a little bit different. It means we didn't look at it as a threat. We looked at it as something to work with. The person who has this challenge parameter didn't say, why me? They said, what now? Challenge does not mean you love your condition. And that's the other thing. When I was doing HIV care in the 80s and 90s, people would say, love your HIV. And a lot of my patients will say, I won't say what they said. You can imagine. No, it's not about loving it or liking it. It's about saying, okay, this is what it is. It is really a form of radical acceptance. What now? The next parameter was control. Oh, I love this word. So many people say that they can control. We want to control everything. The control parameter was, I can't control what happens in the world. I can't control if there's fires in Seattle or Oregon or Washington. I can't control what's happening in the water supply or COVID. Or what I can control is how I want to view these things, how I want to interact with them. And then that just cycles back to the challenge and the commitment parameters. So control. Kobas's original work just had these three. And then some people took her work and said, well, you know, there's really an important fourth component, community. If you don't have community, you could be the hardiest person, but if you're the only person not listening to your doctor and doing what you need to do for yourself, if you're the only person, it can be a little bit difficult, as we all know, especially now in the pandemic. Community is one of the most important factors they found. And if you look at the research on PTSD, one of the preventive factors in developing PTSD after a trauma is a sense of connection, which will make sense in a minute when we talk about the polyvagal theory. So community. And I'm just going to say right now, we're doing this virtually, and that's fantastic that we have the opportunity. Nothing will ever replace being in person. It will regulate your nervous system differently, faster than this. But if this is all we have, what I'm going to encourage everyone right now, talking about mental health, talk to people. Don't text, don't email. It's great for some uses. Call people. Hearing the voice regulates the vagus nerve, which again, I'm going to talk about in a minute. Community is important. And it can also be your cats. I have 3 of them all sitting around me right now. Okay, so let's talk about some resiliency scales. This is the Connor Davidson resiliency scale. It's comprised of 25 items on a 5-point scale, a Likert scale, 0 to 4. Oh, and I have it right here, if you look at those 25-point scale. Do we need to give people the resiliency scale? Yes, you can. What I did over here on the left is I took all 25 of those and I tried to put it into the commitment, challenge, control, and community perspective. That's why that's there. But hopefully this will give you some other ideas about commitment, challenge, and control. Faith, personal or collective goals, that could be considered commitment. Successes, effort. You could put faith in several categories here. So just wanted to give you another way of looking at this. You can find this online, the Connor and Davidson resiliency scale. So I want to move into talking about another neurological way of looking at all of this. And it's called the polyvagal theory, proposed by Stephen Porges. When I work with anyone, the first thing that I want to understand is how they are orienting to the world. What gives them meaning and purpose? That's part of it. But how are they responding to anything coming up? So orientation is the word I use to talk about, how they're reacting and how they respond. So Porges talks about this from a phylogenetic level, and developmental evolutionary level. If you take away that part, we could just say that most mammals respond this way. When there's danger, what do? Is we pause and we evaluate. Okay, what was that? Okay, I want to know. When it's a threat, immediate, right now, most of the time we dissociate. But when we feel safe, then we can engage. And this is what Porges' whole thing about the nervous system is. And let me show you that I use the word orienting because in my trauma training, we talked about the defensive orienting response and the healing orienting response. I don't want to get into the mammals and reptiles and all of that. That's not as relevant right here for our purposes. What's important is when we get triggered, many people can understand that word. When we have trauma, big T, talking about big T trauma, real trauma, and then a lot of us also say, oh, that was traumatic. And we use that in a way that's can be perceived as insulting to people who've really undergone trauma. The other problem with that is no one can tell you what's traumatic. no one knows your own history. We don't know what is triggering. And so we also need to understand how someone orients. The way most mammals do is this first column to the left. And this is what every one of us knows about stress and trauma. Sympathetic activation, that sympathetic innervation, and what we call the fight or flight response, but what I call the mobilization response. We mobilize. It's like, okay, got to do this. Okay. It could be we mentally ruminate. It could be that we're thinking about what to do next. Our body, and we all know this, right? From high school biology. Your heart rate speeds up, your airway is open so that you can see your pupils dilate so that you can look and see where you're scan for the environment. You know, you start to sweat, the blood gets shunted. You don't need to digest your food right now. You don't need to work on your immune system and fighting infection. You need to get those muscles, those large muscles, to move so you can run like mad. Now, mobilization, and now at 3 o'clock in the morning when you're thinking about your mortgage, what are you mobilizing against? You know, and I do this to my students. I always say student loans. I say the word student loans, and you watch their whole body react. But what's interesting, if you're listening to me now and I said mortgage and it had no impact on you, or if it did have an impact on you, right? That means you're already rehearsing something in your mind. You're mobilizing to it. Now, when this gets blocked, we go down this other route. And it's a route that we see turtles do when they go underwater for a long time. It's what possums do when they see that coyote come by and it just freezes. All of this is about saving our metabolic energy, right? So this is not sympathetic. All PTSD, all stress responses are not sympathetically induced. This is parasympathetic induced. An example many people can relate to is if you ever see blood or you go get a blood draw and you see a needle and you feel like you're going to pass out. That's this. This is a parasympathetic. It comes from the dorsal vagus. There's debate about the dorsal vagus, but we do know that the vagus nerve gets involved and everything in your metabolism shuts down. Your heart rate drops, your breathing drops, you could lose consciousness. You could pass out. That's the immobilization response. Now, as advocates, what's important to know is if you're talking with your client or the doctor's provider is talking to the client and they get triggered and overwhelmed, and we say psychologically they dissociate, Porges doesn't necessarily like that term, what's happening is their prefrontal cortex is going offline. They don't have access to their thoughts. They're not being resistant. They're not being difficult. They need to feel safe. Safety needs to be restored before they're going to be able to answer your questions. And that's so important. And in my work in hospice, we learned that at a time of diagnosis, and it doesn't have to be a hospice diagnosis, a terminal, it could be any diagnosis that really is a threat, remember threat. People only retain 20 to 25% of the information they heard. And part of that is this. It could be that they start to mobilize and plan and then they're not listening, but a lot of people immobilize. It's a threat. They just lose consciousness. I mean, they're still standing up. They're not completely losing consciousness, but you understand what I'm saying. Parts of the brain go offline. That's important for us to remember because we need to help the person feel safe. This isn't completely relevant for our talk here. It is so much as the vagus nerve, the 10th cranial nerve. 80% of it is afferent, meaning it's picking up signals from the body and sending it to the brain. And there's a lot of work about when our body sensations don't match the environment. If we have vision and our eyes are open, we're always trying to see, does my internal state match the environment? And so I'm not going to go into that right now, but if you have a virus or a bacteria or any inflammation in your body, your vagus, the glial cells of your vagus are picking up those signals and sending it to the brain stem and saying it's unsafe, shut down. For any of you who want to get geeky about this, there's ideas that people with chronic fatigue and fibromyalgia usually have chronic viral infections. It could be chronic herpes infection. It could be Epstein-Barr. It could be Lyme disease, Bartonella. And when that starts to get activated in the body, the vagus picks it up. You might not feel it, but the vagus picks it up and it sends a signal to the brain, parts of the brain, and say, sick behavior, shut down. When you have a flu, you don't feel like eating, you don't feel like grooming, you don't feel like talking to other people. And they call it in the literature, sick behavior. So safety isn't just, that's what I want to be clear about. Safety isn't just about our perception of what we're seeing. It's also what's going on in the body. So if we have chronic inflammation, if we eat something that we're allergic to and it causes that, our mood can change and we don't know why. None of this happens out of the blue. We're either perceiving something or we're sensing something in our body that's not safe. Okay. And these are examples of it. The turtle naturally engages this dorsal vagus to go underwater because it slows its heart rate down into breathing. The possum does it. And down to the left corner is the smiling snake, one of my favorite snakes, because it has no teeth. It can't defend itself. So what does it do? It just pretends that it's dead. I think it's cute, but I like snakes. There was a study I read that said 40% of mice in the wild die because they activate their dorsal vagus and shut down, and they shut down so much they die. Now, I don't know how they did that study. I want to find out, like, did they have mice wearing monitors? I don't know. But that's a natural thing. Now, this is the healing orienting response. This is the one that we all are going to practice. And this is where all the mind-body techniques that ever exist come into play. I can put I'll take the challenge to put all of them into this. The healing orienting response. We're activating, according to Porges, again, there's some debate about this, the mammalian vagus, which is myelinated, doesn't make it faster, but it's myelinated, and it allows us to engage. This is the thing that every single one of us, if you've had children, if you have pets, you know this. Not everyone knows this instinctively, but it's often a natural reaction. If I just think about the time I came out of my bedroom and I saw that my cat, my beloved cat, who's no longer alive, but Jake, had vomited not on the linoleum, but on the carpet. I mean, like, here's the tile, here's the carpet in the bedroom or the living room and the kitchen. And the first thing I went is, oh, damn it, Jake. And he ran like hell. He knew just from the tone of my voice, my muscle tension. I don't think he speaks English, but who knows. So several months went by and the same thing happened, the same spot. And I said, okay, I'm going to do this. And I went, oh, Jake, I'm going to kill you. And he comes up to me and he rubs up against me because of the intonation of my voice, because of how I was breathing, because of my muscle tension, the tone. All of that is connected to the vagus nerve and actually a number of nerves that come out of the same area of the brain, the nucleus ambiguus. There's a ventral vagal complex and cranial nerve 5, 7, 9, 10, and 11 all come out of there. And so they work in concert and they're all above our neck, our muscles of our shoulder, our neck, the muscles of our voice, our facial muscles. And that's what helps us regulate so we feel safe. If I'm going to go and talk to you and I said, well, I have some serious things to talk to you about, you already react. If I go, I have some things I'd love to talk to you about. It might be a little challenging, but I really want to work on this. You're going to be more interested in engaging with me. Porges calls this social engagement, and I call this just engagement, because it's not just about engaging with others, which again, remember, community is so important. It's also engaging with ourselves. How many times do we feel sensations in our body and they're not safe? We think they're not safe. We start to catastrophize. We start to worry and ruminate about them. And we just activated those two other systems. We either mobilize and secrete more epinephrine and cortisol, which only makes our symptoms worse, or we shut down and we dissociate. And we all do this. I do this. I mean, I can tell you about like all the things that have happened in the past year, right? And there were days that went like, it is too much. and I'll sit on the couch and I'll watch an entire series on something on Netflix. That's another way. It wasn't engaging. I mean, there are ways when you're watching things and you're engaging with it. There's other ways you're just scrolling and just dissociating. So we all do this because it helps protect us. We need to mobilize. I don't want anyone to leave this talk and think we shouldn't mobilize or we shouldn't immobilize. That's not true. We need to do it effectively. And that's what, not the next slide, but the slide after that is. This is a slide talking about engagement, right? When you see this, what happens to you? If you're feeling anything with any of the slides, like the baby sloth or the baby monkeys and the baby, if you're experiencing anything, that's the engagement system. That's the vagus nerve. And we're going to get to that in practices in a minute. And this is talking about, if you can see, this is the dorsal motor nucleus. Right back here, the dorsal motor, this is the ventral vagus, and all these things come out. And so when you look at these pictures, especially these pictures, look at those kittens. I'm sorry, cat fan, obviously. It regulates your nervous system. And I am going to show you that. So this is when the ventral vagus is in its dominant function. We're in more of a parasympathetic state and we can engage. These other systems are still working. They're still going on. I mean, right now, I'm feeling pretty safe. I'm talking to you. I'm still activating my sympathetic nervous system so I can talk, I can engage, I'm engaged, but I'm still activated. And I had food not too long ago, so hopefully I'm digesting it too. Not as much since I'm talking, but. Okay, so we got this theme here. What do we do when we feel triggered? Do we mobilize? That's helpful at times. But as I said, at 3 o'clock in the morning, if you get a diagnosis at 3 o'clock in the morning and you're thinking about it, does it help? I'm not saying we shouldn't do these things. I'm saying, does it help? When we immobilize. Now, these can become dominant functions. These can become our primary way of being. And I do say frequently to the people I work with, we have a productivity-obsessed, death-phobic culture. It's my phrase I keep saying over and over again. And if I can't do something, I'm not worth anything. I don't know where we got that idea. And I'm sure everyone can relate to this on some level. I can. So we don't want mobilization to be our dominant function. And we don't want immobilization to be our dominant function. So when we talk about mental health, we want to look at how we're orienting to things. Now, there's an author, speaker, Johann Hari. I don't know if any of you ever heard of him. He wrote a wonderful book called Lost Connections, another word for engagement. Johann Hari, great talk. He has a wonderful English accent. So I can listen to, I listened to his book on tape, not tape, wow, showing my age, on audio because he reads it himself. And he was on antidepressant medications for, I think, 20 years. And when he went on the first antidepressant, SSRI, he was writing about it and touting how wonderful it was. And his psychotherapist used to say, you're still depressed. So finally, he started to research this in more depth. And he did a great job. His book is full of references, and this is his book. Well, it's everything that I'm saying in a way, right? He says there's 9 causes of depression. And I would say there's 9 causes of anxiety, depression. They're really not that much different. They really aren't if we get into that. We don't feel, he says, disconnected. I'll say engaged with others. Where there's disconnection from our childhood trauma. We could get into ACEs. I'm not talking about ACEs here, but that's a whole other conversation. Oh, wow, meaningful work. Didn't I talk about that in the beginning? If we feel like we're not doing something of meaning connected with our values, I think those are very similar. If we are productivity obsessed and our productivity is connected to our worth, that's going to affect our status. I just think about the number of parents I worked with when their children went off to school and they were alone and empty nesters. Like, well, what's my purpose now? Who am I? What's my status? Now what am I? And I'm going to take it another step further. I just was talking to another patient. with metastatic breast cancer who had a hysterectomy, uterus, ovaries, and had a radical mastectomy, bilateral. And she said to me, with all seriousness, am I still a woman? How are you going to answer that question, right? And that connects with her value, with her status. It's with her identity. So status and identity, I think, are really connected. And what I believe personally, and I share that openly, I share my belief that your worth is not questionable. And I mean that even with elected officials and everything, different things. They might not have to have that job. So I'm sorry, I'm going to move on there. Hope about the future. We could talk a lot about that with hospice work. And we could talk about acceptance of the moment. I'm going to skip over that one. That's a whole other topic. But the other thing is this disconnection with nature. And one of the things I read in New York Times just 2 months ago is this whole new term called eco-anxiety. Eco-anxiety, and they say it's affecting, who's it affecting the most? The younger generation. And 30 to 40% of all teenagers now have been diagnosed with anxiety and depression. And it is not just due to the fact that we're diagnosing with more ease. It is really, they're getting more information constantly about the world and look at the world. And there's a lot of eco-anxiety. They don't feel like there's a hope for nature. Interestingly, Scotland is one of the first countries in the world that has now had reimbursement for nature therapy. As a naturopath, I'm saying amen. Get out in nature. So we feel disconnected with nature. So Johan Hari is saying, if we can start to get these connections back, that doesn't mean the reality's changed. It doesn't mean that nature isn't, there's still fires. It means that we can relate, we can engage with it differently. I think another term for all of this is grief. And we could go into grief. I'm going to just leave it there. So we're going to talk about resiliency. This is what we're talking about. And building a resiliency program. I'm just going to put these up here. It's not really surprising when we talk about all those things that were mentioned here. Community, cultivating passion, humor, and self-regulation skills, meaning in life. And we could just take one of them. But I want to talk about the breath as we're getting close here. I want to talk about the breath and use this as an instrument of self-regulation. Now, I usually do this breath inquiry, but what I'm going to ask you to do is just sit in your normal position for a moment, whatever your normal position is. And this isn't a relaxation exercise. This is actually just an awareness exercise of your breath. And you could just look down. You don't have to look at this at all. And I'm going to invite you to just notice if you're breathing through your nose or your mouth. I'm going to invite you to notice where the breath begins in your body, your torso. Now, many of you already adjusted your breath, already changed your breath. Where does it begin in your body? And what moves most in your body? And notice the rate of your inhale and your exhale. Is the inhale longer? Is the exhale longer? Are they equal? Do they change? One of the patterns might be that it changes every so often. And what's the volume of this inhale and exhale? Does it feel easy or effortless, or does it take some effort? Does it feel staccato or fluid? What's the quality of this breath? And then notice your posture. If you were truly sitting in your normal posture, not an ideal posture, adjust your posture now and see if anything you do can change the flow of your breath. So I'm going to have you come back. I usually do this much longer than this, but I want to just share a few breathing exercises with you. Notice what you observe by just watching the breath. So the breath is regulated by the nervous system. Many of you have seen this, the parasympathetic and the sympathetic nervous system. And I just want to share this about the vagus. So this is parasympathetic and sympathetic influences of the breath. I am going a little bit faster here. That when we get stimulated by the sympathetic to the heart, this is the sinoatrial node of the heart right here. That's the pacemaker. The sympathetic branch goes here and to the AV node, and it releases epinephrine and norepinephrine and makes our heart speed up. But guess what? That's not the first thing. That can happen, but it takes about 5 seconds, which is pretty slow in neurological time. When we exhale, parasympathetic from the vagus stimulates the sinoatrial node, and it actually releases acetylcholine and causes our heart rate instantly to slow down. Instantly to slow down. So we think about the purpose of respiration is to deliver oxygen and remove CO2, and it's really about CO2. A lot of it is about CO2, and I'm skipping some of these slides for sake of time. That when we have too much oxygen, anybody who's ever had a panic attack or have seen someone on TV, right, have a panic, and you overbreathe. You're breathing out so much carbon dioxide and you're inhaling too much oxygen. And in the presence of more oxygen, the hemoglobin here that holds on to the oxygen holds on to it tighter. So what happens? The tissues don't get their oxygen, and the tissues like the blood vessels and the blood vessels and the respiration, the lungs start to constrict. And so what do? You breathe faster. I need more air. I need more air. And what do we tell people to do? Breathe into a paper bag. And they breathe in more carbon dioxide. They recycle their carbon dioxide, and then the oxygen can be released from the hemoglobin and the red blood cell and go to the tissue. So a lot of times when people go, I'm not getting enough air, they actually, if you put a pulse ox on them, they actually are getting enough oxygen. They have too much oxygen. If you ever put a pulse ox on at the doctor's office and it says 99, you have too much oxygen. More isn't better. 97 is great. That will open up the blood vessels and relax. And this is called the Haldane-Bohr dissociation curve. You don't need to remember that. So when we have CO2, now there is a limit, but when we have more CO2 in the system, then our blood pressure, our pH decreases and oxygen can be released. And so can nitric oxide, which allows the blood vessels to open. So just want you to know that I'm going to skip this chemoreceptors. It's just areas of the brain that measure this. And so what we're talking about is overbreathing, hyperventilation, where we can overbreathe. So a number of things can happen when there's too much oxygen. And you can look at this slide, it's very complicated, but just in the presence of too much oxygen, not enough CO2, we can get more pain. We can get greater blood vessel contraction. We can get the heart rate to speed up. And this is one of the favorite biofeedback slides. People share this all the time. This is your brain with normal breathing. A lot of it lights up, and this is what happens when you hyperventilate. It shuts down. Wow. Maybe your patient, when they get a diagnosis, your client goes, when you inhale and hold it, you just sped up your sympathetic nervous system. The worst thing you can say to someone when they're stressed is take a deep breath, because what they do is they take this big breath in. What you really want to do is take a breath out slowly. And these are symptoms. Just look at this. These, in 3 minutes, 3 minutes of hyperventilation, these are the symptoms that can happen within 3 minutes. If you do this for 3 days, this is what can happen. Does this look familiar? This is why I do so much with breath work, because guess what? I'm talking about all these conditions that people are treating. Do you really need herbs for your sinusitis? Do you need herbs for your chronic fatigue, or herbs to sleep? Or maybe you need to learn how to breathe. And you can all feel this if you want to right now. You could just put your fingers on your radial pulse if you know how to do that. And that's my pulse. And you could just feel the beat, space between the heartbeats. Take a breath in and breathe. Feel the heart rate speed up. The space gets smaller. And if you exhale slowly through pursed lips, you can feel your heart rate slow down. And if you have a heart, now if you're on certain blood pressure medications, if you just had a bunch of caffeine, you're not going to feel it. But that's telling us, and it looks like this. This is actually a biofeedback machine. This is the person breathing. This is when they're breathing and their heart rate goes up. And when they exhale, their heart rate goes down. I can show this to you so many ways. So that's a clue. How are people breathing? Now, one of the techniques, I had someone take this of me. This is the first thing I just want to go back to that is, if I can go back to that, is practice breathing. Now, many people have heard of box breathing. They've heard of Andrew Weil does 3, 7, 8 breathing, 4 seconds in, 7 seconds hold, and 8. I recommend to help people settle and regulate, not to do any of those, but just see if you can get an even inhale, even exhale. And if you want, after you do that, so like 3 seconds in, so you can just try that. And 3 seconds out. And if 3 seconds becomes easy, now, by the way, we don't count 1, 2, 3, 1, 2, 3. 1, 2, 3, 1, 2, 3. And when 3 is easy, do 4. And when 4 is easy, you do 5. I want you to notice what's happening. And maybe if you feel your radial pulse, you can even feel your heart rate slowing down. You can do this. You don't need medication. By the way, a trick with all mind-body techniques, the more you try, the worse it will work. Why? Because you're efforting and trying to be productive and perfect. Just allow. And when 4 is easy, then you can do 5. And this is actually one of the techniques I teach absolutely everybody I work with. Now, if you want to take it a step further, you can do alternate nostril breathing, where you breathe in one side of the nostril. For the same thing, do the same count. And then close that side and go to the other. Breathe out the other side. No pauses in between. You just then inhale back from that side, close it at the top of the 3, 4, or 5, and then exhale for 3, 4, or 5, the other side. Inhale for 3, 4, 5 of that side. And then exhale the other side. There have been numerous studies on brain imaging and have shown that people can regulate their brain hemispheres. They can integrate it, and it slows you down. Okay, I know we have to stop, so I just want to just say gratitude. 5 more minutes, I think. Can I show this for 5 minutes? Okay, gratitude. Can't stress the breathing enough, but gratitude is important. And we already talked about engagement. Gratitude and loving kindness, very similar. There is this product called M-Wave. It measures your heart rate variability that I showed you, that heart rate going up when somebody was breathing. And I love to show people what their heart is like. This is one of my students. I had them, I put them on this. I said, think about your student loans. Sorry, I did. And this is their heart rate. It went all over the place. Now, if you don't know how to read this, you'll go, okay, so. Then I said, I want you to imagine breathing in and out of your heart. This is really like the next 2 minutes. And do you see how it started to get more sinusoidal? And then I said, think of someone you love and appreciate without question. This is the same person at the 6th minute. So that was 2, 4. This is from 4 to 6 minutes. Instantly, her heart rate went into this coherent, even thing. If you don't believe thinking about love and appreciation can affect your nervous system, I will love to work with you. Come and see me. I'll put you on a heart rate monitor just to show you. And now I did this at Boston College. I went to a health fair and I worked with 40 people in a row, and every one of them could get into heart rate variability. They could get into this coherent state, but none of them held it for more than a minute and a half. And it kind of went back to this. And I asked them, what were you just thinking? So they were in that state, and they said, I was thinking about my grandson. He's going off to Afghanistan after Thanksgiving. I'm thinking about my husband. He died 2 years ago. I'm thinking about, and that's what we all do. That's what we all do. The narrative. We think about something we love and we immediately think about its loss. What I'm asking us to cultivate is changing the narrative and staying with that love and appreciation, that gratitude. These are just some heart rate variability apps. Gratitude. So not only breathing, but love and appreciation can impact your heart, and you can regulate your nervous system. These are simple techniques, but I really invite you to practice with those. I thought I was going to be done faster, but there's so much there we could talk about.
There's so much there to talk about, and we actually do have about 9 minutes to be able to take questions, if you can believe it. I know. And I just want to say that was fantastic. And for anyone who would like to practice more, actually, Dr. Brad has a free twice weekly 30-minute meditation. I've been doing it regularly. It's a lot about the nostril breathing and loving kindness and all kinds of things, but you can find it on the Breath Space, and it's absolutely free, 30 minutes twice a week on Tuesdays and Thursdays. You'll see a bunch of us there. But I want to open it up for questions for the people who have been listening along. So if you have any questions for Dr. Brad, now would be the time to do that. Anyone questions? Nancy, let's put you on unmute. Hi, Nancy.
I have a question. How do you help someone whose burnout is not, it's not work associated. It's somebody that has suffered significant losses, trauma, and they, in terms of like, they don't care, like it's not there as far as thinking about, they don't even want to think about what's their purpose, what's the meaning, because they're just so completely depleted.
That's a great question. I mean, as I said, I do work with a lot of trauma. And when I talked about burnout, I mean, the way we're looking at that definition is really connected to work. You're burnt out from your work. But what you're talking about is someone who is more in that immobilization stage. And Hansele used to talk about that. He said that we mobilize and then we just get to this adrenal exhaustion point. So I wish that was not as common as it is, but I think that it is. So what we do is try to build up some reserves. What I do is actually, in my practice, start with breathing. I do two things. I talk about the top-down approach with patients. That's more of the cognitive approach. But we also talk about the bottom-up, because that's what we could do. We could change our posture. We can do our breath work. So I teach people paced breathing and show them how they can begin to regulate their nervous system. The thing about that paced breathing specifically is when you activate the vagus nerve through that slow exhale, and I didn't explain this, when I do paced breathing with people, I usually have people breathing about 4 to 6 breaths per minute. So that could be about a 10-second cycle, about 4 seconds in, 6 seconds out. What you're doing when you do that is stimulating the vagus nerve, and it's increasing that vagal tone. What's in the literature is something called vagal tone or vagal braking, so that when triggers happen, they actually can learn to put on the brake. When you get into that state, if we did this for 20 minutes and I had you following a pacer and you just breathed in that way, you will feel differently, unless, of course, you're one of those individuals who's trying to match the pacer perfectly. And you got to be, and I see too many of those. I really do. But when you let that go, when you really can, and just do that, you will feel differently. And I've worked with people with such severe adrenal fatigue, with POTS, with all kinds of physical diagnoses, that their doctors are going, I don't know what's going on. It's like their nervous system is dysregulated. You want to build them up slowly.
Some people might not know what POTS is.
Oh,
if you haven't worked with that before. Yeah.
Yeah, it's postural orthostatic tachycardia. When you sit up and stand, when you sit up and lay down and sit down, your blood pressure and your heart rate just do what they're not supposed to do, not the way it's regulated. So
isn't it related to dysautonomia, where your
dysautonomia,
nervous system isn't working properly?
Yes.
Yeah.
And from my perspective, that's the cause of all disease. That's, maybe I'm overgeneralizing, but I think it's the nervous system is not feeling safe. It's not working properly. It's doing what it was learned to do. We call it our neurobiological adaptive response, meaning you learned it for some reason to take care of you. Now you just don't know how to turn it off. And as Nancy, in your question, you have all these traumatic events happen, and we could talk about ACEs, adverse childhood experiences. You have these events, your nervous system gets hardwired, conditioned to look at the world that way because it wants to be efficient. If my mother, when I'm 3 years old, is very disapproving, that could be life-threatening, right? I can't take care of myself at 3 years old. If I'm 55 and my mother looks at me disapproving, why does my whole heart sink and everything? Because I've conditioned that response. I'm going to survive if she's disapproving. And I know that's a simplistic answer, but that's what we do with everything. And we're conditioned to respond that way. So when you have these traumatic events, your nervous system wants to continue work. I think of it as practice, just like handedness, learning to knit, learning to ski. It's the same thing. We do not, in the medical establishment, afford the same respect to conditioning our nervous system for mental health that we do for any physical thing. We don't talk about its practice, it's training. So I start slow, start with the breath, and I also talk to every single person about safety and what is their nervous system picking up that's unsafe right now. And if they are not safe right now, we have to address that.
Yeah, I think it's a really good point. And one of the things, because it feels like it all comes down to what the individual perceives as a threat. And one of the things I just wanted to make a quick plug also is one of the sessions during this conference is Dr. Michelle Andresic will talk about trauma-informed care. And so she goes into this quite a bit, because at last year's conference on pain and healing, we didn't really get into trauma. So that we're going to get into it just a little bit in her session, which I think people would really enjoy as well.
It fits with this completely.
Yeah, absolutely.
And it's not just about perception. There's the internal experience of what's happening as well. And the other thing is, like with here in Seattle, when we had the fires and the smoke, it's not safe. But what would we do if there's a fire? We would put everybody in a stadium somewhere. Oh, not going to do that during a pandemic. Your body wants to respond. It smells smoke. And then what do we do? And so there's so many factors involved in this. Anyway.
We probably have time for one more question if anybody has one. And if not, no. Okay. Well, thank you so much. This was great. I always learn something. Thank you for so generously sharing your time and your experience. We really appreciate it.
Thank you. I really appreciate being able to share this with you all.